Hi there, I'm Dr. Martin Benfield, I'm a GP trainer, and this video looks at how do we involve the patient in the management explanation stage of the consultation. This is really important because it can shorten consultation lengths, should improve patient satisfaction, and should improve how much the patient remembers from what you are talking about. There are enough uncertainties in medicine without adding into that the uncertainty you get from a patient not understanding what you're saying, or what you're saying doesn't match with what the patient is thinking, or even worse, what the patient's already told you. Broadly, I'm going to split this into two methods. One is to adapt your usual explanation to the things the patient has already said, and then the other would be making the explanation discussion a dialogue between two people rather than just a monologue of the doctor talking at the patient. So at the diagnosis stage, you should be looking to explain your thinking. Think of maths when you were at school. You don't just put the number is 4, you explain your working out. And it's the same with the consultation. You want the patient to leave the consultation understanding how you made your decision, and by doing that you include in your explanation the symptoms, risk factors, ideas, concerns, and you build all that in and adapt your usual explanation to all those factors. So at the diagnosis stage we should be using lines like I think you are right about the diagnosis X as a possible cause, or that event or past diagnosis does make this diagnosis more likely. Having symptoms X and Y suggests that this is the cause. Having this symptom suggests that this isn't the cause. So kind of, you get the idea, that kind of thing. You can build into the discussion how it affects the patient's life. Now, this is a really important question to build into your standard template for when patients are presenting with symptoms. How does it actually affect their life? And do you know the expectations for the patient? Now, obviously you try and get this during the data gathering, but sometimes it's not always possible if the expectations might be about the diagnosis and not so much thought on the treatment until we get to the actual diagnosis being made. So you might need to ask some expectations questions at this stage. But if you imagine a patient has pain affecting mobility, what is their expectation for treatment at this stage? Do they just want some pain relief just to reduce general symptoms? Is pain affecting sleep at night? Do they want to get back so they're fit enough to be able to walk to the shops unaided? Are they wanting to get back to a sport of some kind? So in that scenario, there's no point offering physiotherapy and orthopedic referral if all they want is something to help them sleep a bit better. And on the other end of the spectrum, there's no point just offering some pain relief if actually pain isn't a major issue. They want to be good enough to run a marathon again. When starting the treatment phase, it may be appropriate to clarify these expectations. And so the expectation for treatment, it might not have come out, it might have done, and so you can clarify this. So something like, am I right that you're really looking for a cause of your symptoms as a top priority today, rather than discussing things that might just reduce your symptoms a bit? Am I right the effect on your sleep is the worst thing for you currently? Do you know any of their treatment preferences already? Now, ideally, this is something you would have probed during the consultation already. What have they tried already should be a standard question in most consultations. And if they come out with something, then you follow up with how much did that help, or how did that help, and then did it cause you any problems? And then in the during the treatment phase, you'll be able to say something like, in the past you said you found naproxen pretty helpful. Is that something you'd like to try again this time? Or last time you weren't sure if naproxen helped and you had to stop it because it caused some stomach burning. I'm assuming you're looking for something else instead this time. The other technique we're going to look at today was how to make it more of a dialogue between two people rather than speech from one person. And the main way to do this is the chunk and check approach, which you may have heard of. And with this, with each chunk of information, you then follow up with a check, a question of some kind. If a person is to remember some information you're giving them, they have to process it. and they have to process that new information into the way they see the world. And this goes for any of us learning anything new. Now you need some space, some headspace to process information. You might need to ask a question to clarify something, or to ask something that doesn't quite understand, and then you can process it in. If we start giving our second chunk of information while the person is still processing chunk 1, they're not listening to chunk 2, and you have now lost the patient. So at the very least, you'd be wanting to give a pause after each chunk of information, and it's up to you to decide how much of a chunk to give each time. Even better would be a simple question. So be in the habit of giving a small chunk of information. Does that make sense? You don't want to be doing it too often, because then it sounds patronising, but a reasonable chunk, and then does that make sense? If you feel you've given a fair amount of information, maybe a bit too much, you can almost give permission to say no by saying, I think I gave you quite a bit of information there. Does that make sense? And if the answer back isn't so convincing, no, I think it was all right, well, ask again, are you sure? Give them permission to say, actually, I've got a question. Another nice question to ask or to use sometimes is asking the patient if they want to know any more. So you might feel you've given chunk 1, chunk 2, that's probably enough, and then you could ask, is there anything more you wanted to ask about this, or is there any more information you wanted to know about this condition? It might be about medication. You've given a brief explanation. Is there anything more you wanted to ask about this medication? And then when you finish the treatment plan discussion, try and be in the habit of finishing with a question that checks they're okay. Are you okay with that? Do you have any questions? That would be a very basic question to always have at the end, and obviously you adapt it as appropriate. Are you okay with that? Do you have any questions? We're supposed to check for understanding, patient understanding, after we explain things, and this is almost impossible if what you attempt to do is to ask the patient to recall everything they've just said, and we virtually never do that. A much more realistic way is to check how the patient is going to carry out the management plan. If they can give you answers, then they understand the management plan. So things like, when do you think you'll be able to go to the pharmacy to collect the medication? How are you going to go? How are you going to book the blood test appointment? When do you think you'd be able to do that counselling self-referral form? I notice you don't take any medications in the evening at the moment, and this one's twice a day. How are you going to go about remembering every evening? An adaptation to the chunk and check approach is when you first start an explanation. And what you can do here is give a headline of the chunk and then check if they know anything about that condition already. So something like, I think this is carpal tunnel syndrome. Is that something you've heard of before? And then patient may tell you something and you would say, great, what do you know about it? And then you can go ahead and try and adapt your explanation to what the patient has said. And then your finishing question in that situation could be, does that fit with what you understood by carpal tunnel syndrome or by the condition? Or with a medication, one option would be to use a medication called furosemide, which helps get rid of fluid from the legs. Is that something you've ever tried before or come across in the past? And then you can obviously adapt your explanation as required, appropriate, and finish with, what are your thoughts on that option? So when doctors don't involve the patient, there can often be a prolonged final stage. The doctor gives their explanation, they give the safety net, they think the consultation is over, but the patient has more questions and they didn't quite understand, and it wasn't the treatment that they were expecting, and you end up with this disjointed consultation that might last another 5 minutes or so. I see it all the time in videos, and it's because of a mismatch at the start. So hopefully with this patient-centered techniques that you've been learning in these previous videos, hopefully this won't happen to you again. The next video is about explaining heart failure, and I'm using that as an example of using these techniques we've been covering.